Welcome everyone to the second day of HARC 13, again virtual, unfortunately, but this is the 13th year of doing HARC, and hopefully we can persist even through the pandemic. I know that it's been an extremely trying time for many people, but nonetheless, I think yesterday went really well, and I'm hoping today will also go fantastically well. Some housekeeping notes and some things to look for. I'm hoping that people will go to the posters. It's hard in the virtual context to remember to do that, but please go to the posters. Quite a few of the poster presenters have also posted videos of themselves presenting their posters on the site, and I think it's a really lovely function. Please check out the videos. Also, when you go there is a link to vote for your favorite poster. There's an award for best posters and best abstract presentation. You can select up to 3 from the list on the voting link if you want to go there and vote for your favorite poster. Later today, there's going to be a networking session there. We're hoping that you will turn on your videos so that we can see each other. There will be an evaluation that comes to you through the mail. And please, it'd be great if you would fill them out. You have to do that if you want to apply for continuing education credits anyway. If there are any technical issues today, please check your email or the website for how to get back in. The slides and recordings for all the sessions will be posted in sometime in the next 2 weeks. So please please keep the link active for yourself. You can then come back and get any of the content. The timing of virtual meetings from session to session can be tricky. We're going to try our best to stay on schedule, and then we can move from session to session through the links. The timing can be tricky. Yesterday we did okay. Almost all the sessions started right on time, but we're going to try our best to do that. And with that in mind, with no further ado, it's my very distinct honor to introduce today's keynote speaker, Dr. Claude Yancey. Dr. Yancey is a Vice Dean of Diversity and Inclusion at Northwestern University Feinberg School of Medicine. He's also concurrently the Chief of Cardiology and also the Associate Director of Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He holds many other distinct honors, and I don't want to take any more time from him. So please welcome Dr. Claude Yancey for today's keynote.
Michael, thank you very much for the very kind introduction. Let me share my material. I'll go to the first graphic, and if I can have Daniel confirm that we're seeing the full screen with the background of Chicago, titled 2021 Health Literacy Annual Research Conference, Advancing Health Literacy to Improve Health Equity, Health Literacy and Other Social Determinant of Health. Daniel, can you confirm that we're good with this?
Yep, you're good.
Thank you. Well, thank you for this invitation. I want to be respectful of time and get right into this conversation. This all evolved some time ago when a mutual colleague that I share with Michael Wolf, triangulated with us and suggested that I may be able to provide content referable to your theme, improving health equity. I appreciate Michael's introduction uniquely so today because it does qualify my presence as someone that spends significant time in cardiovascular sciences and cardiovascular medicine, but also someone that's deeply invested in issues of diversity, equity, and inclusion. And the thought process, even thought experiment that we're engaging in today is building a link between your unique focus on health literacy and the foundational circumstances that populate my thinking about disparities, diversity, and equity. I have no relevant disclosures, so let's begin. I want to start with what I just introduced to you. I want you to think about a thought experiment. Now, thought experiments are theoretical constructs where ideas come together and we determine if they promote or provoke any new considerations. So let's start with this schematic of the social determinants of health as it is, That really is the subtitle of what we're trying to argue, that health literacy ought to be populated within the social determinants of health. What are the traditional traits or attributes of the social determinants of health? Neighborhood characteristics, health and healthcare, health seeking behavior, if you will, social and community constructs and contexts, education, economic stability. This quintuple set of descriptors qualifies what we describe as social determinants of health. Michael was very kind to share with me that many of you are demographers, some are epidemiologists, many of you are health service researchers. So this notion of the social determinants of health is not foreign, and you're quite facile with this, I'm certain. But let's continue the thought experiment. This is lifted from an issue of Health Promotions International 2017. And it identifies, again, a thought experiment, trying to understand how do we connect the social experience and some sense of morbidity and mortality, here defined as well-being. Look at the intersectionality of the environment, of health behaviors, of immunology, and then where I live as a classically trained, not only physician, but physiologist, since that was the core of my fundamental research training, there is an acknowledgement that there's a certain pathophysiology involved in this that targets organs. Where this is riveting for a physiologist, a physician, a cardiologist even, is to understand all of the other intersections that ultimately figure into well-being, morbidity, and mortality. I'm obviously setting you up for this thought experiment. And then here is another graphic from the same source that takes us from the sense of well-being and then deconstructs all of the different things that are involved here. How do you live your life? How do you collect health information? What's your family history? What's your ethnicity? What's your culture? And you see here the very important concepts of reading and understanding. So I've taken you through 3 experiments, if you will, for the more global thought experiment. So what are the takeaways from this thought experiment? Takeaway number 1, if we look at the quintuple of characteristics of social determinants of health, health literacy is not included in the traditional model. What's the second takeaway? It's sobering for a physiologist that depends on biology to make decisions about caring for patients with illnesses and or preventing patients from developing illnesses. But in truth, there's this very complex interplay of society, environment, behavior, and immunology, plus the traditional teachings of biology that ultimately determine our health, our well-being, and the burden of diseases. But even in that complex interplay, where does language and communication reside? And then think about this. I think this is really quite striking. How do you source your health information? How do you understand your health information? How literate are you with health information? Because that indeed helps to determine your health. So with that in mind, let's take almost an existential question. Why is this discussion necessary? That is, thinking about health literacy as a component of the social determinants of health in this overarching thematic conference that's looking at health equity and health literacy in an intersectional way. And important, why me? I mean, why did Mike Wolf connect me with Mike and say, maybe you've got something to offer? Maybe this is why. During the height of the pandemic, I was one of the strident authors and spokespersons and speakers that looked very carefully at the influence, impact, the injury, the harm of COVID-19 on special populations, uniquely so for those populations self-described as African Americans. I live in Chicago. I've been here 11 years and I am riveted to Chicago. This is a place that I call home. But I was struck as a journal editor, one of the other things in which I'm involved in, that as we were reviewing information for consideration of publication in JAMA Cardiology, a leading cardiovascular periodical, in came information domestically. We had already published internationally, particularly from Wuhan province in China, but then the domestic information came in about New York City, about Baltimore, about New Orleans, where I lived 5 years, and about Chicago. And what made the data in Chicago so compelling, and I'll get to this momentarily, was that the burden of COVID-19 in self-described African Americans or Blacks was limited to just 5 neighborhoods. So this really argued that perhaps race is important in this dialogue, but maybe place is even more important. But the reason that this particular contribution to the literature was so heavily cited was because we articulated something that many others agreed. The US has needed a trigger to fully address healthcare disparities, and COVID-19 now seemingly was that bellwether event. So if that's the case, what gives me the oomph? What gives me the leverage to be so definitive about COVID-19 as a test case for the extent to which we have health disparities, and in keeping with the themes that we're discussing yesterday and today in this conference, why health literacy ends up factoring to this equation. This is the American Public Media Research website, a site I frequented often during the height of the pandemic, originally aggregating data on a weekly basis, then bi-weekly basis, and continuing this through early 2021. Look at the name of the site, the color of coronavirus. I know you had conversations yesterday about COVID-19, both domestically and internationally. Maybe some of what I'm going to share with you will resonate. But this site captured COVID-19 deaths by race and ethnicity in the United States. Through the last acquisition of data, it became evident in early 2021 that 1 out of every 400 to 500 Indigenous Americans is now dead due to COVID-19. 1 out of every 500 to 600 Black Americans is now dead due to COVID-19. That refrain continues through all the other groups. And you can see here the number of excess deaths through a time when there were only 440,000 US deaths, now over 600,000 US deaths. But then the site did something remarkable. It made a pivot, and it went from aggregating deaths to capturing vaccination rates. So here is the irony. In those groups suffering the greatest burden of COVID-19 with regard to death, mortality, we see the least uptake of the vaccine. Is it possible then that whatever the factors were that were responsible for the vulnerability to COVID-19 were similarly responsible for the hesitancy to receive the vaccination? I know that there's some epidemiologists in your audience, and you are immediately comfortable with this image. This is a heat map. How many times have we used this heat map to describe what I know best, cardiovascular diseases, but other diseases are appropriately described with this approach as well. But there's a different color scheme here. You see shades of purple, you see shades of blue. This heat map is now a heat map of vaccination status due to COVID-19 vulnerability. And the grid is interesting. The grid shows the social vulnerability index, about which I will say much more in the coming moments, and the vaccination coverage. Suffice it to say, for the purposes of this graphic, a social vulnerability index close to 0 means a very resilient community, one that is able to withstand an outsized crisis like a pandemic. Whereas a social vulnerability index close to 1 is a community that's highly vulnerable to even a moderate crisis. And then the shades of blue identify the extent to which vaccination occurs. The distribution geographically cannot be overstated. The shades of blue, that is low social vulnerability index, high exposure to vaccination, appear in the upper Midwest, appear in the Northeast corridor, appear in selected urban areas, appear in the Northwest, appear in West Coast communities. But then look across what we in cardiovascular medicine typically call the stroke belt, and we see shades of bronze, brown, purple, meaning communities very vulnerable to something like COVID-19 and also least exposed to the vaccine. There's a lot of substance in this map, but it says that whatever is responsible for this geographic variability is sinister because it puts people at risk for COVID-19 and its consequences, and seemingly is also associated with a lesser uptake of the vaccine. So I've given you an important introduction intended to get to this point. Part of the discussions about health equity reflect an acknowledgement that there are health disparities. I've just given you this definitive statement that COVID-19 exposed those disparities. As we think about the definition of disparities, we quickly go to this reference document from the then Institute of Medicine, now the National Academy of Medicine, that argued that even in populations with equal access to care, there is a definitive difference in the quality of health care received as a function of minority status. Non-minorities versus minorities, non-minorities have better care. But that difference does not equate immediately to a disparity. Sometimes that difference is clinically appropriate, it's based on biology, it's based on preference, and it's suitable to say that's sufficient to accept that difference. But look at what happens when the difference is not due to biology, not due to appropriateness, when it's due to the way systems are configured, when it's due to the underpinnings of bias and prejudice, racism even. That's when we define a disparity. If you're beginning to think globally, like I'm trying to present to you, you recognize that the thought experiment that we're still creating is one that says justifiably health literacy belongs in this equation. Is the system amenable to the languages spoken by the patients that are being served by that facility? Is there something operative in the subconscious of the providers, of the physicians, of the healthcare team that reflects a bias? And is that bias in part driven by, yes, these geographical community level things that we've just outlined, but is it also a function of health literacy? So let's go from these more global thought experiments and drill down to something more specific. Let's think about unraveling at least some of the root causes for disparities and the necessity to have these conversations about equity. Specifically, let's look at the social determinants of health. How important are they? Well, let me argue they are profoundly important. This graphic from the American Hospital Association, a different kind of AHA, tells us that 20% of a person's health and well-being is related to access to care and quality of services. But then the physical environment, the social determinants and behavioral factors drive 80% of health outcomes. So if the thought experiment that we're building qualifies as an appropriate inclusion of health literacy in the social determinants of health, look how important that might be, because this in aggregate drives 80% of health outcomes. Definitely an important statement. Here's a statement from the other AHA, the American Heart Association, of which I remain a lifelong member and previously served as president. I served as a senior author for this statement from 2015, the social determinants of risk and outcomes for cardiovascular disease based on science, led by a dear friend and colleague out of Colorado, Ed Havernack. So what we did first was to define the social determinants of health as we understood them in 2015. We started with the socioeconomic position. Do you have a job? Do you have an income? Race, ethnicity, social support. We included culture and language, but not literacy. We included access to care, and we included the residential environment. So this became foundational as investigators since that time have begun to think about social determinants of health and this intersectionality with the cardiovascular disease process. So now becomes the important question on the table. Health literacy. Is this another social determinant of health? Well, let's look at some of your own literature. This is published in 2020 in a description of health literacy and health disparities, very apropos for today's discussion. Let's start with health literacy as defined by the Institute of Medicine, now again, National Academy of Medicine. Health literacy represents a limited capacity to obtain, process, and understand the basic health information and services needed to make informed health decisions. That's a pretty powerful definition, one that you understand well, and many of you have no doubt operationalized. But here is a compelling statement from this recent source documentation. 1/3 to 1/2 of the US adult population has limited health literacy. This elevates the importance of these conversations because the vulnerability is substantial. Even more so, this vulnerability is exaggerated. That is, limited health literacy, or LHL, especially affects vulnerable populations. Now, this is beginning to start to resemble a lot of what we experienced with COVID-19 and we're still experiencing. Social vulnerability itself is not necessarily an attribute intrinsic to individuals or different cohorts of individuals, but vulnerability status is determined by how society and its institutions are constructed. And that's where limited health literacy comes into place because it ends up being tightly, and I love this, simultaneously linked to a number of social determinants of health. So every discussion we've been having in health outcomes research about social determinants of health de facto is a shared discussion about limited health literacy. This is a project that started in 2003. It took individuals aged 16 or older who were fluent in either English or Spanish, and then subjected them to surveys of their literacy level, health literacy level, if you will. Once again, you see this prototypical representation by race, by ethnicity, by indigenous status, even by multiracial status, of those that are below basic literacy versus those that are proficient, and in between is basic and intermediate. Now, many of you are investigators, and let me say that by today's world, this kind of depiction as a function of race is inadequate because it does not allow us to understand what constitutes the durability for some and the exposure for others. But let's keep this experiment going now, because in this graphic that shows us the determinations of literacy and the pathways that are involved, we see something that helps us deconstruct the previous graphic. Yes, you start with big groups, some that seemingly are proficient, some that are below the basic functioning level. But look at the importance of the social determinants of health. Look at the intersectionality with structural resources, what's available in communities. Look at the importance of healthcare organizations and their literacy level, particularly their concordant or discordant literacy with patients. Think about access and quality. Think about life events that have led to disruptions for that individual. You begin to understand how health literacy is a much more complicated variable that goes well beyond a limited description reduced to just race and self-designated ethnicity. Moreover, there's a small point of this graphic that is a big issue. Policy drives so much of this. And so if we're making the argument that health literacy is a way to achieve health equity, don't underestimate the importance of policy as the fuel, as the engine that gets us to a different place. But again, in the thought process of challenging these blanket statements that one group is more literate than another group, in addition to understanding the complexity, the journey to health literacy, look at the challenges. Challenge number one, there is significant confounding when we're talking about health literacy because it's deeply interwoven in the assessment of social demographic factors. You heard the previous statement. It is active simultaneously with the social determinants of health. What about reverse causation? Maybe it's attributable to underlying comorbid conditions. Certainly, patients with diabetes, patients with heart failure, patients who are taking a variety of medicines, steroids in particular, may have significant cognitive abnormalities that are not necessarily due to literacy, but in fact are due to underlying conditions. The third challenge, attention bias. This one I think happens every day. There is a demand capacity mismatch where providers are urgent, they want information right away. Health systems are demanding, they want information right away. And in so doing, they put an outsized emphasis on specific communications about detailed data in populations that are already under stress because of the awkwardness of healthcare seeking, and the communications being driven by providers who clearly have a discordant social space with patients. So this attention bias is not to be minimized. And then what about the attribution bias? This is important because this deals with the life journey of literacy. In order to be literate, one has to have access to the right resources. But instead, if there is a history of oppression, a history of marginalization, then there means there has been inexorable exposure to multiple forms of deprivation that becomes manifest as lesser health literacy, or LHL. But maybe what's at play is this attribution bias. And then this last bullet is one that may resonate with you, certainly resonates with me. Who's doing the limited health literacy research? From what communities do they evolve? Are we starting from a foundation where there is a bias in the profile of those who are doing this work? Still challenging this notion of putting people in big buckets defined by race and ethnicity, I think that the final statement here is education. The power of education, simply put, cannot be underestimated. Less than high school education, 49% likelihood to be below the basic level. Graduate studies, senior degrees, high likelihood to be proficient. The power of education cannot be underestimated. So then that gets us into a solution strategy. That is to say, if we think about better communication, advocacy skills on behalf of patients, improving health literacy, making certain it's concordance with culture, building important relationships, developing collaborative styles. If we get to where provider and patient feel aligned, then the purple arrow highlights what may be the utopian aspect of all of this: to build trust, shared respect, and have an alliance between provider and patient. And that improves clinical decision making and leads to better health outcomes. So, if that's where health literacy is as a candidate for inclusion in the social determinants of health, then where is the field of health literacy? That really gets me to the work of Michael Wolff and Michael and his colleagues. Michael is really recognized all over for expertise in mediation analysis. Think about the way we typically do research. We have an observation in one group versus another. Before we can rush and say there's something about that group that is responsible for the observation, we go through a series of adjustments for age, for comorbidities, for sex or gender. We're basically doing a stepwise regression analysis. That is straightforward when there are two axes at play. But what about when there are multiple axes at play? Mediation analysis allows us to look at multiple axes. I particularly enjoy, and I say enjoy intellectually, I'm not happy about patients with asthma having these burdens, but I'm engaged with this graphic because asthma is not only a very important condition, but it's a prototypical condition where health disparities have been well described. Each solid line you see here between the boxes, you see the descriptors on the left margin, you see low health literacy and income in the center, you see the disease process asthma on the right margin. Each solid line describes a statistically important association. Asserting causality, as we all know, is very hard in this kind of work, but establishing an association and linking multiple, in this case, boxes, really is informative. And it gives us a sense that there is reason to believe that low health literacy, low income, and all the other characteristics on the left side have an interconnectedness and relate to the quality of life for patients with asthma. I particularly enjoy this statement. This was authored by our chair, but by many colleagues as well. The title, Health Literacy and Power. Let me submit to you that this is a pause moment. I was intrigued in the pre-meeting session. Michael and I were having a very friendly conversation. He saw my screensaver, changed his screensaver to a Van Gogh. I talked to Daniel. We went through different iterations of headsets and microphones so we could transmit clearly. And then Michael really got my attention and introduced me not to one, but to two experts in ASL communication. Think about the privilege all of this represents, the ability to be facile with communication in such an immediate manner to optimize the messages that you're receiving today. And then I picked up this quote from this defining statement: the field of health literacy asks all of us, what can we do with our educational privilege to make things better for those who haven't enjoyed our good fortune? Imagine what happens if every discussion about health has exactly the resources that you have to make certain the communications are clear, that everyone can access the information equally, and that there is equity in delivering the message because there is an adjustment made in the way the message is delivered that's appropriate for the necessities of a given cohort in the population. Really is food for thought. So now really reaching the peak of our conversation, health literacy, another social determinant of health. Well, let's go back to COVID-19 and see just how malignant the social determinants of health might be. You've seen this graphic, but it allows us to restate the perspective here. This outsized burden of COVID-19 is a function of race and ethnicity. Several of us, when I say us, I mean colleagues of mine that think deeply about issues of disparity, equity, and inclusion, authored a number of important statements. I'll show you two of those. This is from William Owen, and I really like William's work, Failing Another National Stress Test on Disparities. In describing the same situations that we describe, William said, we propose that the overarching cause of these tragic statistics is decades of the effects of adverse social determinants of health. Now, detractors would say, wait a minute, you're saying that somebody else caused this and that people impacted with the burden of COVID-19 have no responsibility. No, we're not saying that. We agree. People must make good choices. That's why I'm so deeply immersed in advocacy and community education. But here is the takeaway phrase, but they must have good choices to make. It gets back to that attribution bias that I took deliberate time to explore before. Great colleagues, David Williams at Harvard and Lisa Coop at Hopkins. We've shared many a stage together and we've shared publications together. They argue that compared with white individuals, African Americans have higher rates of uninsurance and, get this, underinsurance, challenging the fallacy that the Affordable Care Act provided sufficient insurance to all persons. But they went on to say the segregation of healthcare per se contributes to these disparities because it limits access to primary care. But importantly, what we and others describe, they are making it very clear that social inequities are patterned by place. And that the problem of segregation, and this is really getting into a serious dialogue, because what we're suggesting is that these social inequities, these social determinants of health, to which health literacy, that is limited health literacy, may be added, really are characteristic of segregation. The problem of segregation is not residing among persons of the same race. We have a choice. We should live with those with whom we join. But the clustering of social disadvantage paired with the systematic disinvestment in marginalized communities is what's driving this. These striking disparities we've seen in COVID-19 really do lead to a disproportionate burden on vulnerable members in the community. And what we need to work towards now, yes, we have a vaccine, but we need something else that makes us immune to these negative social determinants, up to and including limited health literacy. So that means we need to be able to identify, or we would wish to identify, communities that are vulnerable. I told you I would get back to the social vulnerability index. I described it with just one or two sentences before, but I'll be more clear now. Because what we're talking about is the ability to approximate those social determinants of health, which simultaneously reside with limited health literacy. From 15 variables in the United States Census, it is possible to aggregate characteristics of communities, truly at the community level, zip code, or even tighter, and assign a score. 0 is lowest vulnerability. 1 is highest vulnerability. You can see the website, very active. You can search the community of interest and identify the social vulnerability index. Let me give you an example. I'm giving this presentation from Streeterville, Chicago, on the campus of Northwestern University Feinberg School of Medicine. I also live in the same community a half mile away. What do you suppose the social vulnerability index is at a major academic medical center in downtown Chicago? It's pretty close to 0, meaning lowest vulnerability, highest resilience. Move this cursor just 10 miles south, prototypical south side of Chicago, the social vulnerability index predictably is 1. Now, for demographers and epidemiologists, that doesn't strike you as earth-shattering, but let's keep this going. Now I'm sharing with you the COVID-19 cases in Chicago by zip code. Remember, I told you that what promoted and provoked the statement we put in the literature in the spring of 2020 was this observation that the disease appeared to be limited to just several communities. Here are the communities on the south side, and then here are the communities on the west side. South, predominantly African American, serving or Black. West side, Hispanic or Latinx. Those are the cases by zip code. Here are the social vulnerability indices by zip code. An interesting overlay. And what happens when you overlay fatalities from COVID-19? So as I argued, as Williams and Cooper argued, the issue at play here is less about race and it's more about place. Geography is where all of this resides, and the social vulnerability indices represent our best approximation for the social determinants of health, to which we are now considering the addition of limited health literacy. Another difficult moment for you. In a keynote address, you should be given reason to pause and think. Here's a definition of structural racism, a trigger phrase. But if we think about this academically, scientifically, if you will, there is an operational definition that is important, and I'll just read the first sentence. A system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. The rest of the definition is there. I acknowledge many in the community don't agree with this definition, but this is not my definition. This is sourced from a referable group of parties that come together and think strategically about the health of our society and argue that these barriers are in place. But I want to take you to the next level and have you read the statement from C.S. Lewis. Again, I want you to think about the thought experiment here of incorporating limited health literacy to these same social determinants of health. I'll pause for 8 seconds and let you read this quietly. The impact is greater if you read it yourself. What's the point here? The point here is that the pandemic, but other conditions as well, make evident that the life and living circumstances of people is associated with their vulnerability to diseases. Those living circumstances are aptly described by the social determinants of health, to which we are now adding limited health literacy. These things exist in communities. It looks like the structure of the community is the problem, but you remember the emphasis on policy before? We see that it's people that are responsible for the structure of certain communities. Decisions have been made that have a great bearing on health. How can I be so definitive? You've heard about the phenomenon of redlining. This emanated post-World War I as a way to promote housing to address a housing crisis in this country. The federal government decided to back home mortgages, but created the Homeowner Loan Corporation in the 1930s, the HOLC, and assigned them the task of declaring creditworthiness in different communities across the country. If your community had the lowest creditworthiness, you received a D grade, and on the map, it was circled literally with a red line. Adjacent communities would receive a C grade and so forth and so on. What was not understood was the sinister influence of segregation, which was rampant in the early decades of the 20th century. This is the red line map of Chicago from the 1930s. You see the communities targeted. Ordinarily, you would think that if you were in a community where you could not receive a mortgage, you'd move to one where you could. But because of segregation, it was the reverse. And more African Americans moved into these communities outlined by the red marks. Interestingly, then, when I go back and share with you the burden of COVID-19 by zip code, by social vulnerability index, by fatalities, it replicates this redlining map from the 1930s, and it argues that a policy put in place 90 years ago may be the reason why the social determinants of health are so adverse in these communities. And again, the partnership of the social determinants of health and limited health literacy is precisely what's on the table today. If I step out of my office right now and get on the train and go to Inglewood, it's about a 10 to 12 mile ride. But for each neighborhood I traverse, life expectancy falls by nearly 10 years. So much so that here in Streeterville, it's 90 years. In Inglewood, it's 6 years, 30-year difference in life expectancy. What's the name of that line? The red line. So one more thought experiment before I close. Does nature prevail over social determinants of health? I've already shared with you what I think is a malignancy of this, but is there something about biology that supersedes the social determinants of health? Let's take hypertension. Everybody knows that Black individuals have a much higher burden of hypertension. I had the privilege of co-chairing the Data Safety Monitoring Board for this major trial known as a SPRINT trial, which determined the best way to treat hypertension. But there was an important sub-study led by colleagues of mine at the University of Texas Southwestern Medical Center, looking at a group of individuals in that study for whom we had genetic ancestor information, and in trying to identify were the outcomes in SPRINT a function of their genetics or something else. You can see the way in which this was put together, the precision used to survey the ancestry information, the referent populations, particularly the Yoruba trial in Nigeria, which is really the source documentation for West African genetic ancestry. Very well done. You see the adjustments for the social determinants of health. The data were indistinguishable, even though we were able to identify those with the greatest representation of West African genetic ancestry and those with the least. So much so that in an accompanying editorial written by one of my colleagues at the NHLBI, this statement was made: social and environmental factors as opposed to West African ancestry likely play more critical roles in determining racial disparities in hypertension. This is very important because those who argue that there's just something about being Black, there's nothing about being Black except where you live, and it certainly does not serve as a proxy for your ancestry. Even when you measure your ancestry, what overwhelms this? The social determinants of health, to which we're adding limited health literacy. There are other means of measuring social determinants of health. I know some of you are active investigators. The Area Deprivation Index, the Distressed Communities Index, geocoding, and make certain that if you're doing this kind of work, you only use self-reported race and ethnicity. But if we look at the Area Deprivation Index, we see education that gets close to the themes of this conference, but we don't see literacy. We see income, housing, and household characteristics demarcated as you see under the variable column. The Distressed Communities Index is interesting to me because now there's 7 metrics and 5 tiers, so we can go from those most vulnerable again to those most resilient. But yes, you see no high school diploma. Inferring literacy is important, but it's not explicitly stated. So that gets us to my closing graphic. And again, in my conversations with Michael, I really thought carefully about what did he want to accomplish with this. And so the question that came to mind, this is kind of a derivation of our conversation, will the 100 or so of you that are participating in this discussion walk away with new knowledge? And I would argue there are several points that should influence you in response to this question. As astute scientists and careful observers of the human experience, we are influenced by social experiences. Those experiences now are sharply highlighted by issues of bias, race, and racism. That is an evident truth. Health disparities, another evident truth, represent pressing healthcare challenges and need more research, hopefully executed by many of you. I want to be very clear. Race is a surrogate for biology as a field proxy, and even race as a surrogate for the social construct, including the social determinants of health, is a poor proxy. If the conversation is about the social model, then it should be specific. Target the social determinants of health at the community level. Use one of the tools we've identified. And then the takeaway message to the traditional assessment of social determinants of health, the time has come to have a reasonable consideration of the inclusion of health literacy. If we do that, then our future research efforts will be much more sophisticated, and our ability to understand root causes and to really assess how we can improve communities, preferably through policy, thinking about the social determinants of health and limited health literacy, will be successful. I want to thank you very much for this opportunity to come to a remarkable conference, one that I've not participated in before, but one that I'm really pleased to have been invited to come and visit. Thank you, and I think there is time, Michael and Daniel, for questions. Greatly
Yes,
appreciate this invitation.
thank you very much. It's really great to hear you talking about this. And I wanted to pick up on a few topics. I think actually that will be concordant with your thinking, but I'd like to draw you out to see if, to have more thoughts on. One is I really do think it's fantastic for you to make sure that we think about place and, the different ways people do research on small area variation and different ways of thinking about place. One part of place that we spoke about is education. And you put up graphics early on about how the importance of education and how that has a massive impact on this conversation as a background to this whole thing. But there also are significant, basically racist policies around place when you talk about education. I don't know if you wanted to take an opportunity to just expand a little bit about education and place.
I'm happy to do that because I think we're again getting closer to root causes. Here in Chicago, I've had the privilege of working with high schools on the west side and south side, trying to identify talent, raw talent that has an interest in science. And a consistent observation, one school in particular where I've been supporting their science program for a decade now, is that quite frankly, the schools are underfunded, the teachers are less experienced, and the intentions, albeit they noble, are not really able to be executed fully. And so it's pretty evident that this whole idea of disinvestment is not something that is a supposition. This disinvestment is real. It has to do with what resources are made available to the schools, what teachers are employed in the schools, and when there is an effective STEM teacher, isn't it interesting that that teacher gets a promotion, typically a promotion to another district, teaching another set of students, and the teacher who comes in, again, less experience, recent grad, etc. And so I think that ends up being important. I share with you that during the several years in which I worked inside the NIH as an advisor to Francis Collins, one of the projects that I was assigned was to address why we had a dearth of basic science investigators from underrepresented communities. And we started in the K through 12 space, and we were able to identify important root causes: no support for science fairs, coaches that were assigned the education of science and math, no resources in the classroom, no ability to do science experiments. These things go on and on and on. And so rather than get into a diatribe here, I'll just simply say that the disinvestment that we see based on housing, based on education, based on availability of fresh fruits and vegetables, based on ability to exercise safely, applies to education. That's why policy, I think, is an important lever to pull as we try to think about this.
Yes, and one of the largest policies that influence many of the things you're talking about in terms of investment and the, in schools, is that much of schooling in the United States is paid for by local property taxes. And so it just kind of bakes into the equation, the poverty, basically, bakes it into intergenerational poverty. But let me pick up on this as another part of this. The framing of SDOH, the framing of social determinants of health, I think has really opened an opportunity for people like us to engage in this space. Some people, and I really do celebrate the fact that you're embracing this, the idea that health literacy should be thought of in this way. But are these variables really just derivatives of poverty? Is that not the way that we should? I mean, I'm happy with this new framing, but many of them seem connected so tightly to poverty. And so it'd be great to hear your thoughts about that.
So this is an important question with an answer that may be difficult for some to appreciate. When we look carefully at adverse health outcomes, and again, go through the usual regression exercise and adjust for SCS, adjust for poverty, importantly, differences persist in health outcomes. And particularly for communities that are very heterogeneous, like those that are Latino, Latinx, and those that are self-described as Black, you cannot ascribe a consistent biology. So you are forced to think about issues that are outside of that realm. So that means that, yes, poverty is important. And one of the ways out of this is to improve the economic circumstances in the communities at risk. But where we can't escape is the subconscious bias that's driven by the way in which we deal with people who are different from ourselves. And if we are consistently undersourcing certain communities in Chicago, South and West Side, in Boston, I'm sure there are similar communities. And I just visited with my colleagues in Montefiore this morning. The Bronx is certainly a prototype of that. Then whatever's driving that behavior, which is not biology, is actually driving, as Gladys Pico-Gleason says, obesity in Latino communities, hypertension in Black communities. There are some familial tendencies. I won't get away from my biological underpinnings, but the majority of the disease burden we see is, like the American Hospital Association said, it is about the community, the environment, the social factors. And it's a big wake-up call for us. We can't fix this with a pill, Michael. We can only fix this with a bit of social reengineering, a bit of focus, and a much better policy approach.
Oh, I absolutely agree. There's not going to be a pill for this. I do want to point out that Cindy Brock put a link into the chat for the AHIQ SDOH database, which includes the SVI that Dr. Yancey spoke about, of course. But also to point out that the database doesn't include health literacy. Now,
right,
and which is the topic of the conversation. And
let me push back on you for that.
Yeah,
because part of what I was confused as I was going through the literature in your space is that these scores are assigned and they seemingly are arbitrary, as if it's an empiric scale. I mean, how do we capture health literacy, at least semi-quantifiable, so we can build it into SVIs and distressed community indices? Where is that evidence base? Where is that methodology?
No, that's an excellent point. And the reason why it's not in the AHRQ site is because we don't have the data. And I know that Cindy would advocate for its presence there if the data were available. One way to point this out is that the National Center for Education Statistics, whose data you put up early in your talk, unfortunately, those were data from like 2003 or something, like
17 years ago.
So it's overdue for the next National Health Literacy survey. Yes, Cindy agrees that if the data were there, she would, of course, advocate for its inclusion.
Okay.
So there have been some efforts to create derived health literacy measures. In fact, Stacey Bailey and Fang Gang and I and others have a national map at the census tract level, publicly available for health literacy. I'll put the link in the chat at some point. But effectively, though, to do that, we had to actually create a model. And the model, unfortunately, reflects the educational divide. And we basically have to lean on other variables to create such a model. And yeah, it's a painful model to look at because it shows massive race and ethnic education divide. So now I'm going to turn to the next thing, which is, we know that divide exists, that this educational divide exists, and yet somehow we still have a health system that's so complicated that we magnify those underlying disparities and then concretize them into we're part of that problem. So I don't know if you have thoughts or at this point reflections on what will it take for public health and for the health system to not be part of the problem, to actually care about empowering people who don't have this educational privilege.
So Michael, I'm going to send you a holiday greeting card because I love that you raised that question. I'm going to give you some very specific responses because to extend your thought process, it's not only been concretized, it's been archived. So it's there to educate generations to come unless we can deconstruct it. I don't think the way to do this is in fact, deconstructing it. Nor do I think the way to do this is constant advocacy like we're doing this morning. Here's the way we do this. We start with leadership. We have to have leaders in healthcare systems and the public health enterprise that are sensitive to the discussions that you as MPO, I like the way your audience refers to you, and me as CWI are articulating, saying that, enough's enough. If we want to control the burden of disease, control the health expenditures, and improve our economic circumstances by having a healthier workforce, we need to think about what's happening at the community level. Changes like this don't happen ground up. They're too difficult. Leaders in C-suites have to say this is important, and the way leaders really emphasize importance in this country? Budget. If leaders in C-suites attribute budget and then drive policy, then that's how this begins to change with a much greater speed than anything else we can do. The second thing is to appreciate that diversity has value, not because we're trying to change the way the placemat looks or we're trying to be socially aware, but because by bringing diverse people into the room, we get diverse ideas. I am not a fan of diversity as an issue of representativeness. I'm a fan of diversity as a concept that leads to diversity of thought. So what I'm getting at is leadership and diversity for the reasons that I've articulated. I actually will stop there because there's a question in the chat that I think both you and I should address, because someone named Janet, and I apologize for not knowing your last name. I try to be deferential and respect people. The question is about the difference between fundamental literacy and health literacy. And I can take on the health literacy piece because I agree. I don't think it should be a proxy for fundamental literacy, because I think there are a lot of things we own in this side of the street. We use arcane language. We use terrible graphics. We have no way to communicate with people who don't just know our vernacular. It's not about fundamental literacy. It's about being uncomfortable, unfamiliar with terms, with vernacular. And so I own that piece, and I think that's a big place where we need to go. But Michael, I would love your appreciation, your insight on fundamental literacy. I can think about that as strictly in terms of education, but I would much rather hear a learned view on that.
Well, it is a foundational issue for this field, is the intersection between these phenomenon. Maybe just you had cited some work from Dean Schillinger earlier on.
Yes.
Also, by the way, Janet is Janet Oheen Frempong. She that's so just calling her out. Yes, thank you. So one of the things that you mentioned, like, we just make things so complicated as clinicians all the time. Dean I don't know, maybe like 18 years ago or something, he did a project where he wanted to get a sense of how to measure the massive amount of jargon that clinicians put out. And so he did this audio tape project. And in order to do it, he actually had to come up with a new metric, and it was JPM, jargon per minute. And the average clinician was through the roof with their JPM metrics, but we have to wrap this up because we have two sessions starting now. Thank you very much for bringing this topic to us so well. Everything's going to be on the website, so people can share this, please. The video of Dr. Yancey. And I do think that this topic, is going to have legs. Promoting health literacy as a social determinant is actually, I think, a very important angle here in this conversation. So thank you very much. I hope people will jump to the next rooms. I'll see you there. Be well.
Thanks so much. Have a good day.